Welcome, everyone. I'm Alisha Holland. I'm an associate professor in the government department, and I'll be your moderator today. Today's event is part of a series of conversations that we've been having about the impacts of COVID-19 in Latin America. It will be recorded, and you can also find the recordings of past events on Dr. Class's YouTube channel, and also check out announcements of upcoming events on Dr. Class's website. But today we're really lucky to have a terrific panel to discuss the uneven impacts of COVID-19 by race and ethnicity in Latin America. And this discussion is co-sponsored by the Afro-Latin American Research Institute at Harvard. Ilari also has a great program on Afro-Latinx issues that you can see on their website. Now, even though you have a different moderator today, the basic ground rules for the session are the same. So you can ask questions throughout today's talk through the Q&A function. Our panelists are going to speak for roughly 10 minutes, and then we'll draw questions from the audience for the remaining roughly 45 minutes of discussion. And I have two wonderful co-hosts here today who are going to help moderate the question portion. So Steve Levitsky, do you want to say hi?
Hi, everyone. Welcome.
Great. And then we also have Fran Hagopian.
Hi, welcome, everyone. We're really excited about this session today. Thank you for joining us.
Great. So now let me introduce our panelists today, and I'll introduce them in the order that we're going to hear from them. So first off, we have Marcia Castro. She's part of the home team here at Harvard, where she's the Andelot Professor of Demography, and somehow was also roped into being the chair of the Department of Global Health and Population. And she's done extensive work in the Brazilian Amazon, including a project that's close to my own interests on the impact of large-scale development projects, as well as a number of projects really focused on public health, including mapping malaria transmission and developing new environmental approaches to urban health. So we're thrilled to have her with us today. Second, we're going to hear from Alberto Diaz-Cayeros, who's joining us from Stanford University, where he also seems to have been roped into a major administrative role directing the Center for Latin American Studies, on top of his appointments at the Freeman Spogli Institute for International Studies and in the Political Science Department at Stanford. And he's written numerous articles, including insightful work on indigenous institutions and public goods provision in Mexico, as well as two really important books. So I had my class in Latin American politics read Alberto's first book last week, Federalism, Fiscal Authority, and Centralization in Latin America. And next week, they're going to be reading Alberto's co-authored book, The Political Logic of Poverty Relief. So two really important books. Thanks for joining us today. And then third, we're going to hear from Edward Tellis, who's the Distinguished Professor of Sociology at the University of California, Irvine. And Professor Tellis has written extensively on color, race, and ethnicity, including serving as the principal investigator for the Project on Ethnicity and Race in Latin America, known by its acronym PERLA. And that's produced really important advances in how we measure and think about race on social surveys. And many of those insights are captured in Tellis's really fabulous book, Pigmentocracies: Ethnicity, Race, and Color in Latin America. Now, so thanks for being with us. Now, unfortunately, we were supposed to have a fourth panelist, Veronica Figueroa. She actually can't join today because she is in Mapuche Indigenous territory with terrible internet connection. So we can imagine some of the impacts that COVID-19 is having, and especially digital education in a place without great internet. So we're sorry that she won't be able to join us, but without further ado, I want to kick us off and have Marcia Castro begin by giving us her perspective.
Thanks so much, Alisha, and thanks, Dr. Class, for organizing this. Okay, so So the question in hand here is the racial and ethnic disparities when you look at the indicators of COVID. And in public health, we have a framework that we call the social determinants of health, which is really important to start any discussions about inequalities in health outcomes, in health access. And the beautiful thing about this framework is that it goes from the individual level, individual characteristics, all the way up to households, communities, political actions, the environment. So it's called social because it deals with society, but there are many different factors here. And, you know, if you quickly glance at this table, you can see all the different factors included in there. And each one of those could be connected to inequalities in a country, inequalities, including racial inequalities. So even before COVID started in Brazil, and my focus here is on Brazil, what we see is that Brazil was on a really good path in decreasing the levels of poverty and decreasing inequality. So the top graph on the right shows the Gini coefficient, which is one measure that describes the income inequality in a country. So Brazil historically has very high income inequality. We start with above 0.5 in 2012. It's coming down with the different policy actions that Brazil was having, but then the 2015 economic recession comes, and then the path completely changes. So by the time we reach 2018, the levels of inequality are higher than they were in 2012. And this study just came out last week, and basically the authors are saying, well, Brazil is really on the path of another lost decade. So Brazil in the 80s had a lost decade, and now it's in the path of another lost decade. The graph in the bottom shows three different ways of measuring poverty, and it doesn't matter which way you look at. Basically, what we see is that the poverty levels in 2018, they are either at the same levels of the beginning of the decade or even worse. Okay, so another argument for that. So another thing to keep in mind is if we look at the growth of income between 2015 and 2018, 80% of this growth was among the richest, the top 5%. And in 2019, the top 10 wealthy people in the country concentrated 55% of the income. So this is even before COVID, okay? Here's another measure, again, before COVID. If we look at the disparities in life expectancy at birth, in other words, the average number of years you would expect people to live, first, there are huge disparities across the different states in Brazil. And we have this imaginary line dividing the north that has worse indicators and the south that has better indicators. But the most important message in this graph is that the disparity between blacks and whites, and blacks in Brazil includes blacks and mixed race, is about 3 years. But this can go above 7 years for some of the states in the North region. Okay, again, this is before COVID. Just one more number. This is the Human Development Index, and we can calculate this for each municipality, but basically the Human Development Index combines measures of education, income, and longevity. And what you can see is that the three lines in the middle, the purple line is the line for Brazil and how it changed from 2017 to 2016. The yellow and the green lines are basically the index for males and females. So not much disparity between the two and not much disparity with the overall average for Brazil. However, if you look at the disparities by race, the top line is for whites, so the highest human developed index, and the lowest right there in the bottom is for blacks. Okay, so that's sort of the scenario Brazil had even before COVID. There were inequalities, regional, racial, they were all there. Now, over the past 30 years, Brazil had one tool that actually allowed a lot of those inequalities to be reduced. So reducing inequalities in access to health, in mortality, in infant mortality, and that tool is the unified health system, a health system that is universal, free of charge. And in fact, Brazil is one of the few countries that wrote in the constitution that health is a human right and a duty of the state. Okay, so Brazil had all the tools to basically provide a response to the pandemic, with a health system that actually recognizes those inequalities. One of the main premises of the health system is to guarantee equity, right? So what really happened? So Brazil failed to use its universal health system and failed to use what is the largest community-based primary care program in the world. In other words, Brazil has a primary care program that has community health agents that live in the areas where they serve, where they work. And those agents, they know exactly where the poor people are, where the people that cannot practice social and physical distancing, the people that cannot work remotely, people that don't have access to internet. You were just discussing this in the beginning. People that don't have water at home. This was not used by the federal government. So basically, in the absence of a response from the federal level, what we saw in Brazil were local responses that really, some of them did a phenomenal job in incorporating the health system, in incorporating the primary care. But this was more the exception than the rule. So the response of COVID in Brazil is a story of many local responses that took the problem at heart and provided a solution. In some of them, it's the action of mayors and governors, and in probably most of them is that combined with philanthropy, the industry, community organizations that really came together to develop systems that would monitor data, because those systems are even better than the official records, to create apps to monitor elderly if they have any fever or if they have anything, so you can have a prompt response, to provide food, to provide cleaning, alcohol gel, and so all of those things were responses that we observed at the local level, and we have many of those. However, Brazil has a continental size. It's 5,570 municipalities, and there is no way we could see this kind of mobilization in all of them, especially if you consider that almost a quarter of those municipalities have less than 5,000 people and very limited resources. So what's the end result of this? If we look at indigenous populations, the indigenous populations in Brazil were affected in a much higher rate than the total population. And by the way, this was pretty much the same that we saw in the US. So the figure on the left gives you numbers for September. I just got the numbers as of yesterday. We have about 161 ethnicities affected. That's more than half of the total ethnicities in Brazil. And in terms of the number of cases, it's 4,308 cases per 100,000 indigenous peoples. And if you compare the rate for the total population, it's 2,930. So a huge difference. If you look at deaths, it's also much higher among the indigenous population, 97.9 per 100,000 compared to 84.5 per 100,000 in the total population. Now, it's even worse when you look at the map of the Amazon biome in the bottom that covers all the different countries that have portions of the Amazon forest. In Brazil, by far, except with one area, I believe in Peru, has by far the highest incidence of COVID among its indigenous population. So basically, it's not a favorable scenario, and it keeps increasing. So those were the numbers from yesterday, but disproportionately affecting indigenous groups, both in cases and in deaths. When we look by racial categories, it's pretty much the same story. And here, there are many different studies showing the huge disparities in both incidence, but also in mortality among the Blacks and mixed race in Brazil. So if we just look at maternal mortality, if we think of pregnant women, puerperal women, so overall maternal mortality, the mortality among Black women in Brazil is almost 2 times higher than the rate observed for whites. If we look at people that are admitted to the hospital with COVID, the mortality among Blacks and mixed is also almost twice of that compared to the whites. So basically what we see is that we have almost this double burden on the vulnerable and vulnerable here includes all kinds of groups. It's both income and racial categories. But on the one hand, those people already have poor health outcomes. They have comorbidities that can put them into a higher risk of dying because of the social determinants of health. But on the other hand, they have the kinds of jobs, for example, that don't allow them to stay at home, to work remotely. So they have to take public transportation that is extremely crowded and again increase the exposure. So it's almost like you have this double exposure to not only being infected, but also to die of COVID. And on the top, I put a reference of an article that came out in the Washington Post, which I think it's a good read because it basically tells the story of 2 Brazilians. One, it's a wealthy doctor. The other one is somebody that lives in a favela. The story basically starts all the same. They both got COVID, and from there, it's 2 different tales. Now, one additional thing I want to mention, and that's my last slide, is that what we are seeing is that those inequalities that Brazil already had even before COVID, then all the outcomes we are seeing with COVID, this is going to lead to a scenario of increasing inequalities. So whatever scenario we had before COVID, it's just going to get worse. So the gap between the haves and the have-nots is just increasing even more in Brazil. And we're still going through the economic recession. That's not fixed yet. So when you put all of this together, and when you consider the huge demand for healthcare, one, because we are seeing now that people that survived COVID have some complications, cardiovascular and neurological, that we're just learning. We don't even know exactly the entire, spectrum of disease that they can have. So that's one. Also, because since the primary care was not functioning as it should, there is an expectation that we're going to see worsened conditions of other health outcomes because, prenatal care was not doing the same, surveillance of people with diabetes, high blood pressure, none of that was happening as it should. So we can also have a high demand for that. And last but not least, the demand for mental health care is also enormous. And here I'm just showing a paper that came out yesterday on the Lancet, basically showing that 1 in 5 COVID patients is later diagnosed with a mental illness. So only imagine the huge demand that it's out there for mental health care in the population. And there's only one way, literally only one way Brazil is going to be able to address this huge demand, address this increasing demand in a way that reduces inequality, in a way that is equitable, and which is through their health system. So the bottom line is Brazil has the tools to try to address the damage in a way that reduces those inequalities, in a way that is inclusive and equitable. But it has to use the tools that it has. So it doesn't have to reinvent the wheel. That's the key message here. It has the tools, but for Pete's sake, it has to use them. Thank you.
Thank you so much, Marcia. That was such a comprehensive picture of the disparities both prior to COVID, now during COVID, and then what we can expect going forward. So now I want to turn it over to Alberto, who is going to tell us a bit about, I imagine, Mexico and disparities that we're seeing there.
Thank you very much, Alisha. Thank you, Fran and Steve, for the invitation, and to the community at the doctoral class. It's really a pleasure to be here, and I'm already learning a lot in the first 10, 15 minutes, so I'm sure we're going to have a very useful exchange. I'm going to be talking in a way about some variation of the same themes, but in different manifestation, because in some ways the Mexico case, hopefully will give us some food for thought. And I'm going to mostly center on the impact of COVID on indigenous communities. Let me share my screen. I will put up these slides available in my webpage, and and also I'm sure I'm going to be able to send them to Alisha. But I want to start with this image, which comes from a codex, the Irvine Codex, and this is the 1545 Cocoliztli epidemic. And this is, recorded by the indigenous scribes. This is an hemorrhagic fever, probably some kind of nobody's really sure, but some hantavirus. I don't think it was salmonellosis, as some scholars have said. But what you see here is the indigenous peoples basically telling their own story of their own experience with epidemics. And I'm going to go back to this in a little bit more. So indigenous peoples in Mexico, I don't want to talk about them as an ethnic minority. I think they're a historically excluded group. The intercensal survey of INEGI, which is it's not a real census, it's a sample, estimated 25.6 million indigenous peoples in 2015. If any of you have kept track of numbers in Mexico, the typical number people talk about is 10, 13 million. The intercensus shows 25. This would be 20% of the population. And every survey we have been doing over the last decade shows that by self-adscription and also by linguistic reporting, not only when you ask people whether they consider themselves indigenous, but even in the willingness to tell an enumerator that they speak an indigenous language, all the numbers are growing in Mexico, and they're going to be larger in the 2020 census for sure. I have to also say something about when we say indigenous peoples, that's a misnomer. We really should start learning to speak about them as Nahua communities, 1.7 million, according to this census, Maya communities, the Yucatec Maya, which are distinct from other Maya groups, the Zapotec or the Mixtec or the Tzotzil or the Tzeltal. Each of these groups I'm talking about are about 500,000 each of them, and 56 additional numbers of linguistic groups we can think of in Mexico. This comes from the CDI. There's different, well, CDI, it's called now INPI, National Institute for Indigenous Peoples. But these are the areas of the country that are municipalities where more than 40% of the population is indigenous, or municipalities where at least 5,000 people self-ascribe as indigenous. And of course, any of you who know a little bit about the geography of Mexico will immediately notice that these are also some of the poorest areas in the country. Coneval, which is the Mexican institute in charge of poverty measurement, has been doing for several years now something quite remarkable, which is they've been tracking the evolution of poverty within the indigenous population. This was not possible to do until the 2010s for something that is mind-boggling, which is the following. The income distribution surveys in Mexico did not ask whether someone was indigenous until the 2010s, I'm sorry. So we could not even do this properly until the last four surveys. But what Coneval does is this incredibly sophisticated methodological approach, which they look at both income, so poverty levels usually are done with a poverty line. So they look at income, and that's poverty by income. That's the vertical line there. So if you're below the poverty line, you're either a moderately poor or an extreme poor household. But then they also look at whether you have basic satisfactors, a toilet, drinking water, electricity, things we associate with, very obvious quality of life. And this is kind of an additive process, but having any of these items missing, even if you have a higher income level, means that you are in some ways maybe not poor by income, but you are vulnerable by social deprivation. So what this graph shows you is precisely the mapping of indigenous populations within this methodology. 28% in extreme poverty, 44% in moderate poverty. Then you have about 20% who are vulnerable because they're lacking basic public goods. And also you have another 8%, I'm sorry, no, not 8%, 2% that are vulnerable because they have low income, even though they have every facility. But what I want to center is more on the green square there. And the square there, it shows us the small, very small number of people who are not poor, who are indigenous in Mexico. And that's just 6.6% of the population. Basically, if you're indigenous, you either don't have basic things like a toilet and you are below the poverty line, period. And that, you can see the green areas over here are for the overall population of the country. That's 22% for the overall population of the country. The country is poor, but indigenous people are much poorer. Now, if we look at the COVID itself, and I'm now shifting into sort of work in progress, some of these things I'm still working on them, but the case fatality rate, which is one of the ways in which we try to see the impact, the differential impact of the epidemic on the indigenous population, we can use, the Mexican government has been releasing all the tests. These are individual data sets. So these are 2 million, more than 2 million tests. And we do have a marker. Initially, they were only releasing the data with indigenous by language. Now they also do the indigenous by self-adscription. So you actually see that there's, this 2x2 table is because there's some people that are indigenous, reporting themselves being indigenous by language, but they don't believe that they are indigenous. That's the 3,000 which are in the bottom. Or there's people who consider themselves indigenous but do not speak an indigenous language. That's the 6% on that other side. The 9,000, I'm sorry, 9,700 people. You can see that the numbers of indigenous people affected by COVID in the overall picture, or affected, tested for COVID in the overall picture, are not very large, but the case fatality rate is almost twice the case fatality rate of non-indigenous people, particularly by language. So we're talking about this comparison between 9.8 and 5.7 or 5.8. If you look at this through time, this is a little bit tricky because the data for indigenous peoples is more sparse. This is weekly. What you're seeing is every week, the case fatality ratio. The right panel is the indigenous population. The left panel is everyone in the testing data set. And what you can see is, the way the epidemic curve behaved in Mexico. Don't believe the last couple of weeks, the last few weeks there, because you have a delay in reporting of the deaths. So very often those last data points always show a decrease in the epidemic. But you can see that, this is a lowest regression. It's just a depiction statistically, but it shows you that the indigenous case fatality ratios are way up there compared to the rest of the population. Some institutions, this is, for example, CIESAS, have tried to do some kind of dashboards about this. So this is the CIESAS dashboard, which is explicitly a dashboard trying to show the indigenous populations. So this is similar to the map I showed you at the very beginning. This is just a snapshot of their dashboard. They're keeping track of where the different cases are found. And they're trying to analyze the spread, the territorial spread of the pandemic in indigenous regions. The problem with a lot of what is going on with this kind of dashboard or this kind of approach is that we're probably failing to see most of the cases that are circulating in many of these regions. So let me sort of show you the way I have tried to approach this, and this is work that I started doing with some colleagues in the University of California in San Diego. We have done a lot of work trying to look at inequalities of health, separating the death certificates by deciles of poverty in the municipal level. So basically the problem is you don't necessarily know who is dying and their socioeconomic status of the individual who might be dying. You know some things about their education and things like that. But in general, what you do know very clearly is where they live. And what we do is we separate into deciles the population. So each of these bins you see in this graph is 10% of the population in the country. So the 10% on the right are the 10% who live in the richest municipalities of the country. There's just like 20 or 30 municipalities there. In the left side, you have like 700 municipalities, which are the poorest municipalities in the country. But this is by population. So in general, if you look at a graph like this, if you put death certificates, for example, in a graph like this, it more or less looks the same across different deciles. Some deaths from some diseases, musculoskeletal diseases or neoplasms or hepatitis in men, they actually look really flat. So you basically have the death certificates in Mexico are showing the same number of deaths across all these groups. But for example, something like diarrhea looks very different. There's many more deaths of diarrhea in the poorest places in the country. So the line kind of goes down, or actually respiratory diseases kind of go upwards. This is the pattern of the data of the 2 million certificates we have right now in Mexico. It includes also the negative tests, because one of the things I've discovered the more I work with this data is that a lot of the Mexican data of negative tests are actually false positives. They are COVID deaths. So this is the full death of what they call IRAG, acute respiratory infection. And you can see that, there seems to be something that suggests, okay, maybe the people on the left of this graph are not really being infected by COVID. So this would be a very different picture from the one we just heard on Brazil. But it is also possible that what we're actually looking here is that we have all these missing excess deaths. The Mexican government has actually already calculated their first best estimate of what the excess deaths might look like. They think right now Mexico has about 100,000 deaths, not 95,000 in the latest numbers from COVID, but they think the excess deaths is about 200,000. I here distribute, I call it a possible distribution. I first call it a guesstimate. It's not a statistical exercise. It's just using what I know about the epidemiology of death in Mexico. Maybe this is the way that excess deaths looks in Mexico, with the highest deaths actually happening in middle-sized cities where the epidemic is still raging. And then you have this potential missing data in a lot of the poorest municipalities in the country. It could be that this graph is wrong. It could be that actually those places have been able to withstand the epidemic a bit better. But this is my best guess of how you would distribute. And I should note, some people have maybe paid attention to this, but Mexico has the highest case fatality ratio in the world. It has probably the third highest deaths per 100,000. So this graph is built on the idea of 54 deaths per 100,000. Marcia showed us 94 per 100,000 for the indigenous populations in Brazil. Of course, what we really want to know is the infection fatality rate. The problem is it's somewhere in between, and we don't know exactly if it's 8%. That's the case fatality rate in Mexico right now, huge. Or 154 per 100,000, and somewhere in between is the infection fatality rate. Okay, now I promised to tell you about indigenous peoples, and I'm running out of time, so I do want to show you this is what happens when you do the exact same exercise with the case fatality ratio by indigenous language. So here I'm giving you the 6% is the case fatality ratio of the population of Mexicans overall, but the indigenous populations, there seems to be a lower case fatality ratio on the lower income deciles. I don't think that's true. I think it's just misreporting. We really don't know what's going on in the bottom 20 or 30% of the of the population who lives in those municipalities, about half of the municipalities of Mexico, I would say. And then you see that actually at the top in the 8 and 9 deciles, being indigenous might not be really, a thing that increases your likelihood of dying from the disease, because you probably do have access to, first-rate hospitals, to the IMSS and the different health facilities that the country has. So this again includes all the deaths. I'm not separating only the case fatality ratio from positive COVID tests. For those of you who might not believe me, and this, I'm calling it my Deaton graphs. Deaton has, made some, Angus Deaton, very forceful critiques of this, even from his very early work on how do we study with income surveys and things like that. But this is a really complicated OLS estimates and probit estimates. They have state fixed effects, comorbidities, single individual level comorbidities. So they're controlling for the fact that indigenous peoples are more likely to be sick from pre-existing conditions than non-indigenous peoples. They have municipal level standardized robust errors, I'm sorry. So this is really, even with torturing the data, I'm pretty sure that what we are seeing in the previous graph is really true, that the case fatality ratio for indigenous people. So this is a bit different from Brazil. It's not that indigenous people show in the data as having more prevalence of COVID, but there is no question, I think, in Mexico that they're dying at twice the rate as the rest of the population. So to finish, I do want to say that most of what we want to know, we don't know. And we really have a huge challenge ahead of us. On the one hand, we do know that indigenous communities have been using forms of social governance, social distancing norms, a very different level of trust and a very different mechanisms of enforcement to create these cordons sanitaires that are trying to hinder transmission. And we don't know a lot about that. We're doing right now a survey actually trying to learn a little bit about what is being done by indigenous communities. We really know very little about how public health infrastructure in these regions is working and the accountability of these underserved indigenous communities, the health accountability. We know very little about the credibility of public messaging. Remember, this was a country where the president started by saying he was not particularly worried about the virus, and he still shows up without the mask, without face coverings. There might be some differences in genetic makeup. We just, my friends who know about this tell me we really don't know. We know so little about the genes and the genetic kind of conditions in the virus, but there might be some differences in susceptibility, infection, and survival. Maybe indigenous peoples are actually more resistant than we think, and most of the failures I am showing you here are about something else. But then most of the municipalities where we would like to know what's going on, which the government called them municipios de la esperanza, are really places where we fail to register. We have very little health access. We don't really know what's going on. I would end by saying something that in the 1546 epidemic of Cocolitzli, Fryer would say that one of the big challenges of that epidemic is nobody kept count. He says he personally buried 10,000 Indians. In my own work, for example, I've been looking at all the letters from the viceroys at the time, and the viceroy of that era, looking at every letter in the Archivo General de Indias, never mentions that there's an epidemic raging in what is today Mexico. Thank you.
Wow, wonderful. Thank you so much, Alberto. And thank you for highlighting how much we still need to learn and the gaps in information in particular. All right, so we have one final presentation from Edward Tellis.
I'm not a public health expert, but anyway, first of all, thank you, and I'm honored to be here, and glad to meet all of these people that I've read but I've never met, except for Marcia, and who I know. And I'm not a public health expert, so I want to start by saying that. But I can give, but I can give you a background about race, ethnicity in Latin America that I think is important for this. And so what I want to talk about is my project on PERLA, Project on Ethnicity, Race, in Latin America, and talk little bit about data, and then I want to, then about the things about race and ethnicity that I suppose could lead to COVID exposure. And so I didn't know the data. What Marcia and Alberto presented were fascinating and gives me a lot better perspective. My own research has been on race in Brazil, especially on the Black to white continuum, and then on Blacks and Indigenous in several Latin American countries. And my PERLA survey included several Latin American countries, but especially Brazil, Colombia, Mexico, and Peru. And so I became more interested in the difference between Black in indigenous populations. And when we studied Mexico, of course, the focus was on indigenous population, and Brazil was on the Black population, Peru on the indigenous population, and Colombia we focused on the Black population there, but it has a balance of roughly equal populations of Black and indigenous people. So Latin America, of course, is divided into areas that tend to be more Black or more of African descent, and other places that are more indigenous. So in that sense, the country, the study of race and ethnicity has kind of been divided between these two very different sets of countries, and there's very little unification of trying to understand Blacks and indigenous under similar paradigms. So as we know in Latin America, I mean, there's similar histories of the decimation, I mean, the conquest by Europeans, of the indigenous population. I mean, similarities between the US and most Latin American countries in terms of the conquest and then later decimation and sort of repopulation. There's similar histories of slavery, and then subsequent European immigration in the 18th and 19th century. But that's pretty much where the similarities, or where the comparison ends. So mostly it's largely differences, and one of those differences is a history of actual and kind of a fabled race mixture. So this kind of segregation that you had in the US, so the segregation laws against, the laws for segregation against race mixing and definitions of who's Black and who's fits in particular categories were pretty much absent in Latin America. And Latin America developed this narrative, or most Latin American countries developed narratives of mestizaje or of race mixture. So that's had big consequences for the ways race and ethnicity is played out in these countries. So there was actually more, I mean, you could argue that there was more race mixture in Latin America, largely because the Spanish and Portuguese came mostly as men, and they took indigenous and Afro-descendant women as mates, often forcibly, but the mixture has really been played up by the national narratives and kind of showing this idea that, you know, we're not like the US. I mean, we have this moral superiority to the US, and indeed, you know, we're not racist. It actually came up to the whole idea that we're not racist. But that changed in the last 20 years of a couple, as Alberto is noted. There's been this kind of multicultural turn in the last 20 or 30 years, where Latin American countries have recognized, many Latin American countries have recognized historical racial discriminations and inequalities, and especially in Brazil, I would say, and have begun data collection that they never had. I mean, most countries didn't collect data on Black and indigenous population until very recently, in the last 20 years or so. Brazil, Cuba have had these histories. There's been questions on indigenous speakers in places like Mexico and Bolivia for a long time, but they're starting to collect more data, and more of the countries. So the graph I wanted to show you was actually a graph of the indigenous and Afro-descendant population throughout in the 19 countries of Latin America, and it basically almost every country collects data on its indigenous population. Cuba and Dominican Republic don't, but they claim that they don't have an indigenous population, and as of 2015, half of the countries, 9 of the 19 countries collected data on the Afro-descendant population. And that's even changed subsequently. And Mexico is currently collecting data on its Afro-descendant population in 2020, for example. So the graph that I was going to show you, that I was going to put it up there to let you ponder, but it's my technological incompetence. I wasn't able to do that. But it shows that that on this data, I mean, first of all, the numbers are huge. I mean, they're much larger than the United States. The Black population is depending on how you count the Black population, varies from 112 million to 133 million in 2015, using the best data available. And the indigenous population is about 40 million. Now that is, and then it showed the variation, for example, is in Venezuela. It depends on how you count the population. The Black population can vary anywhere from 3.5% to 53% of the population. And that's because it depends if you include people that are considered moreno. So in Venezuela has this new category that they added in the 2011 census called moreno. And moreno, the government claimed that, well, this is the Black population, but many people probably that wouldn't be considered Afro-descendant are considered moreno, which is about half the Venezuelan population. And then there's these ambiguities all over the place. Alberto mentioned in the case of Mexico that there's about 20 million indigenous people, according to the latest counts. Well, in the 2010 census, using the question on identity, there were only about 10 million. So that number is actually increasing. It's increasing very rapidly, but largely because, I mean, a lot of it's because of consciousness and people reclassifying, not that the population is actually growing. They're growing because of fertility and migration, of course, but there's increasing consciousness of this. And then the questions are changing so that it's not only based on language, but also based on identities or self-identification. Okay, so I went on a lot about data. Oh, one other thing I wanted to add in the Pigmentocracies book is that in the Perla project, we discovered that skin color is a real important dimension of ethnicity and race, but it's not something that's recognized by data collection agencies. So that if you want to see the real racial hierarchy in Latin America is on the basis of skin color. So you have these mestizaje narratives where the population, Mexico, for example, probably, the large majority of Mexicans would be considered mestizo, but the whole idea of skin color cuts through this cover of this capacious category of mestizo and shows big distinctions among the so-called mestizo population. We have light mestizos and dark mestizos. So that's something that we don't that will never be covered, probably for a long time be covered in large scale data collection efforts, but that doesn't mean it doesn't exist. So it's just something to be aware of. Now, so how much time? I don't have much time. Okay.
Probably should wrap up pretty soon.
Okay, so let me just tell you a little bit about the inequalities. Inequalities are, and I thought about exposure to COVID. I don't have the, I mean, I was happy to see the data that the two panelists before me presented on COVID, but one of the questions that was asked is, I mean, is this race or class? I mean, it's more complicated than that. I mean, Black and Indigenous are clearly in the lower classes because they're Black and Indigenous, but also there's also purely race reasons as well. For example, there is clearly issues. There are issues of discrimination in healthcare and access to hospitalization. But there's also the whole issue that some historians are increasingly talking about is how nations underdevelop places where indigenous people and Black people were concentrated. So as Marcia mentioned, lower SES of the population means more overcrowded housing, poorer sanitation, greater use of public transportation. Black and indigenous are concentrated and poor in these underdeveloped regions like Amazonia, Chocó in Colombia, the Northeast in Brazil, Southern Mexico, the highlands in the Mesoamerica and the Andes. And issues of lacking health insurance. There's another issue I think it's really clear throughout Latin America is this idea that Black and indigenous women are concentrated in domestic service occupations, where they were often some of the first, from what I've seen, the way COVID's spread, probably the first that were exposed to COVID because COVID was brought by these middle-class white travelers that came back to Latin America. Greater comorbidities, the data is very clear, as Marcia showed. And then there's the special populations, I think, that are for Blacks, especially in Brazil. I know that they're the incarcerated, where they're in overcrowded conditions, homeless, a large homeless population, street people, and people, of course, in favelas, which are very overcrowded. The one issue that I would say that's to their advantage is age. That Blacks, I think indigenous people, most places tend to be younger. So anyways, I'll end there. Thank you.
Great, thank you so much. So we already have lots of questions from the audience, so let me throw a few out to each of the panelists to get us started, and just feel free to answer any part of them so that we have time to get as many questions as possible. So Marcia, so you really stress that the primary healthcare system is the answer and the way out of COVID for Brazil, and several people in the audience wanted to hear more about this point. So first, how does distrust of the medical system affect indigenous and Afro-Brazilian communities and the reliance on the system to respond to disparities during COVID-19? And then second, there are a bunch of questions about sort of which tools of the primary health system are most important to responding to COVID and more specifically to reducing racial disparities. So which parts of the health system were deactivated by Bolsonaro or just broke down during the pandemic? You also received several questions about state responses in terms of social policy, but let me pull out one in particular that was for both you and Alberto, which is really about subnational responses to COVID. So, both Brazil and Mexico are cases with sort of, populist national responses, but a lot of subnational variation. So which factors account for more comprehensive subnational health responses in Brazil and Mexico? And can you see in any of the data that you've analyzed that is resulting in reduced disparities between Afro-Indigenous and majority populations? And then Alberto, you also stress the difference in differentiating among historically excluded groups, and perhaps you can tell us a little bit more about the variation in outcomes that you might be starting to see across Indigenous groups. I also wanted to hear a little bit more about how you connect what you're doing now to your past work on traditional governance arrangements and uso y costumbres. Do you expect to see better health outcomes when you do see the lead taken by traditional governance institutions, and do any of your data point in that direction thus far? You also have a question on whether there are any data on Afro-Mexicans being impacted by COVID and disparities along those dimensions. And then, Ed, you had a question about differences across groups, and really, given that you think across Latin America and the United States, what similarities or differences do you see between Indigenous and African American populations being affected, say, in the US Southwest, and Afro-Indigenous and Afro-Mestizo populations in Latin America? So again, don't feel like you need to answer all of those, but why don't we go in the order of the panelists, and then hopefully we'll still have time for one more round of questions. So Marcia, do you want to lead us off?
Sure. So those are all terrific questions. So let's see. In terms of the health system, it's important to remember that before we had this national universal free of access health system, what we had was basically health care for people that were in the formal market. So if you had a job, if you have an employer, then you had access to health care. If you were in the informal sector, if you were unemployed, you had nothing. You basically had the philanthropy. There were some hospitals that basically would do philanthropy, but there's no preventive care. It's just when you get sick, you try to go to those places and you get some care. So it's important to see the distinction of Brazil before we had this health system. A few things that make it really different is, one, it has this community-based primary care. So we have teams of nurses, a doctor, nurse assistants that actually go to the house where people live, to those communities, the more vulnerable communities, and they monitor the elderly, the children, the pregnant women. So they provide the kind of care that before this program was implemented, people didn't have access to. And just this primary care program was responsible for reducing infant mortality rate in Brazil, maternal mortality, reducing avoidable mortality, reducing the racial inequality in mortality, and the list is long. So, happy to provide reference if anybody want to read about this. So that's one aspect. The second one is, it was because of the austerity measures that were implemented back in 2016, froze the budget for health. So this is all before COVID. So by the time COVID comes, the health system is very underfunded. It's really operating without enough resources. And on top of this, Brazil has a sort of three-part funding of the health system. Some comes from the federal level, some from the state, some from the municipality. And there is a minimum percentage of resources that have to be passed on to the municipality by each one of those levels. When we look at the data over time, what was happening was that the amount of funding coming from the federal level and the state level was reducing over time with this crisis. So municipalities had to bear a much larger burden of financing health, and some of the municipalities just cannot afford that. And another crazy thing is, if you look at the total volume of expenses on health in Brazil, more than half of them belong to the private sector, not to the private sector, to the public sector, although 75% of the Brazilian population depends solely on the public system. So we had distortions right from the beginning. Now, the problem is, while every other country in the world envy Brazil for having this health system, the government does not value the health system. The people that have private insurance, they don't recognize the importance of the health system. And the media does not help either, because whenever they want to talk about the health system, they don't talk about the good things they do. They only show the lines or people laying on the floor. Usually it's in hospitals in Rio, because Rio has a horrible, health system, in terms of the offerings that they have. So the potential is this. The potential is because it's universal. They are close to the people. They go to the houses. They bring care, preventive care, to places that before had nothing. Now, despite the fact that it was underfunded, despite the fact that it was not being valued, it was not being used, it was not being organized, a lot of deaths were prevented by the health system. And the reason that some municipalities were able to expand the number of hospital beds, the number of ICU beds, was through the public system, not through the private. Okay, so it's important to keep in mind that you could only imagine how it would have been if it was planned accordingly and used correctly right from the beginning. Okay. Now, in terms of the issues of the local responses, it's really a combination. And we have a lot of favelas, communities that organized themselves, had support from the academia. And here I really have to, shoot out for researchers and the public universities in Brazil that are receiving less funding and yet are really pushing knowledge to the limit. Really, it's an example of being resilient and providing a response in a huge moment. So they paired with researchers, private sector, philanthropy, or community groups, students that were just volunteering, and they created a million different things. And in some municipalities, they brought those community health agents, and they were provided of training, masks, protective equipment to be able to be on the ground. So in some favelas, people were going there every single day, house by house, monitoring people. But again, we have a collection of those great examples, and they did save lives. But that cannot be the response of a country the size of Brazil. We needed a federal response, and that wasn't there. So I'll stop here. I'll try to answer the questions here as well. So.
Perfect. So let's turn it over to Alberto, and we'll try to keep answers short just to see if we can squeeze in a few more questions.
Okay, so no, these are all great questions, and I'm just going to build on some of Marcia's answers. One of the things I think we should highlight, and this panel just makes it so visible and so obvious to me, is how different the health systems in Brazil and Mexico are, and how much of kind of underspecified it is if we say things like, oh, federalism matters for coronavirus response. I think to a large extent, and this is a question that Sarah is asking, I mean, the question is correct in the sense of thinking about how subnational governments and states play different roles in a federal system from a unitary system. But to a large extent, I would say that Mexico was in the worst position it could have been to respond to the coronavirus, because it was just dismantling the Seguro Popular that had been created as a solution to the kind of thing that Marcia has described in Brazil with the SUS, and they were creating the INSABI, which most governors did not really want. So Mexico was really in a bad place when the coronavirus hit, even though it had learned an enormous amount from the H1N1 flu, and it had learned a lot about epidemiological surveillance. So the Mexican case does have a lot of elements that have to do also with this kind of overconfidence bias. At the beginning, they thought they could track the epidemic much better than I think they did. And a lot of the failures, I think, are really about the failures of the health system that we've been dragging for 20 years or 30 years. They're not new problems. That links with the question of how do communities respond. I would say that to a large extent, we just don't know enough. I mean, Alisha, I was trying to work a little bit on the data with the municipalities, the indigenous municipalities, the usos y costumbres. It's just hard. I mean, it's hard to work on this, but it's the kind of work we will have to do. And that's why we're putting this survey out in the field. The way we're approaching it is we have alumni, indigenous students who have been alumni in exchange programs in the US, and they're going to become our informants in the communities where they are, because we just don't have any systematic way. We're trying to collect a different set of surveys in the Mije region, in the central valleys of Oaxaca, and in the Purépecha Meseta. And those surveys, because we have to do them social distancing, we're doing it to telephone interviews in establishments, in business establishments, they're being a disaster. We're just not getting a lot of answers. And it's very hard, I think, for people in the pandemic to build up the trust that you need. So that leads me to the other part about what the indigenous communities have much better than any other institution in Mexico, I think, is the trust that exists within the community. And we just don't know enough. I mean, we don't know how these mechanisms are building up. For example, things like believing that a mask helps or doesn't help. But as I say this, I do want to say that somebody in the chat asks a question about whether we can say something more about what governments could do. And I would say that one of the worst things the Mexican government did is it started, for example, tracking the cases of COVID in indigenous communities. And they would always say things like, because they have traditional medicine, because they have cultural forms, we should be keeping in mind that that's kind of what is going to be distinct about them. And I think what is distinct about indigenous communities in Mexico, at least, is that they have different forms of governance, different ways in which they construct trust and they respond publicly. That's what we should be stressing and learning from, rather than saying, oh, because they're, this paternalistic attitude, oh, they're indigenous, they have different belief systems and we have to help them because God forbid they might get infected if we don't help them. Sorry, I'll stop. I'm getting a little mad when I say this.
All right, wonderful. A quick word from Ed, and then we're going to try to fit in a lightning round.
But just real quick, I just, as bad as comparing U.S. in Latin America, I mean, as bad as the U.S. been in its response, it's just institutionally so much stronger. And this amazes me in the case of Brazil, how civil society is really stepped up in the absence, and it was very clear before Bolsonaro. I don't know how they elected Bolsonaro, but it's just amazing. I mean, I don't think the U.S. has anything near that.
Okay, so filling in the gap. So wonderful. So I'm going to turn it over to Steve Levitsky to fire off one last question, and then we'll have a quick round.
Fire off one last question. Okay.
So we're 3, but no more.
No, just one. And this is for everyone who wants to jump on it. I don't mean to gloss over differences between the Mexican and Brazilian cases, but these are two cases that are generally believed to at least at the federal level, responded quite poorly to the pandemic, and yet, somewhat surprisingly, have retained pretty steady public support levels. Bolsonaro's support has gone up. AMLO's has remained pretty stable, particularly among the poor. So my question is simply what we know, if anything, about how Afro-Brazilian and indigenous communities, how public support has or has not changed for the government among these affected communities, not necessarily low income, but specifically Afro-Brazilian and indigenous communities. And secondly, I guess there is a second question, whether there's been any sort of political mobilization in response to the highly unequal effects of the pandemic.
So what we have is part of the support is because before taking term, Bolsonaro was highly against the minimum income, which is any kind of cash transfer. In fact, at some point, he was not even in favor of Bolsa Familia. And then when COVID came, he instituted this minimum benefit to support low-income families that were really struggling because of the physical distancing and remote work, some of them that couldn't do remote work. Now, what he realized is how popular he would become because he was providing the minimum income. And the income the government provided during COVID was like more than 3 times higher the income of Bolsa Familia. So it was, in fact, if you look at the recent data that the Census Bureau just collected, you see a small reduction in inequality because this income was really large compared to Bolsa Familia. So one of the reasons his popularity is going up is because of this minimum income and because people now want him to stay in order to continue providing income. And a lot of people are really worried about this because now that he found out about that could be his secret weapon, not so secret actually, in 2 years. Now, that said, there are groups, both indigenous and Afro-Brazilians, that are really organized, putting their voice out there. And there are a lot of movements connected to the local elections that are going to happen this Sunday to choose mayors and the local legislators. But has this created any political reaction? No, it hasn't. It hasn't created a reaction in the Ministry of Health to target those populations. We have another minister for social whatever. It's a female minister. No reaction at all. So do we have new programs in trying to address exactly those disparities in those groups? The answer is also no. So it's a very crazy story to some extent, but that's pretty much what's going on, at least in Brazil.
Yeah, Steve, I think your question is is terribly difficult to answer. In terms of Mexico, to me, the crux of the matter is something about how you build expectations of what the state should or should not provide when there's a health emergency. So how are those expectations built and constructed? We have democracies throughout the region, and that's not just about Latin America, about Mexico, it's about Latin America, I think, as a whole, in which poor citizens are still quite used to the idea that you show up at a health clinic and there's no medicine, the doctor doesn't show up, the nurses are not there. That's part of the reality of life. So in surveys in Mexico, for example, about customer satisfaction, it turns out that the poorer you are, the more satisfied you are with the health system, even though you might have waited longer hours than the person who is richer, even though you got probably much lower quality of care. But the problem is a little bit about the counterfactual. What is it that could have happened otherwise? So we don't know a lot about the way in which people, for example, are decided. Part of the reason we have excess mortality is people are deciding not to go to health clinics and dying at home if they're old age, or and that's more likely to happen the poorer you are. So the kind of the support to the public response of AMLO to COVID, I think he was able to normalize or neutralize that in some ways the death was something that was going to happen, and that he was doing everything to prevent more deaths than could have happened. Now, what that threshold should look like, if we put the government to account, the government said there would be 30,000 deaths in the most catastrophic scenario. Mexico has 95,000 and probably 200,000 if we include excess mortality. But we don't create that kind of metric when we think about accountability of our governments.
Do you want to add anything on?
No.
Okay. We actually have 5 minutes left. So Fran, you can throw out one last super quick question and then we'll wrap up.
Okay, and I won't be like Steve. I'll actually ask just one. My question is about where we go from here. We've had an outstanding presentations about what broke down in the healthcare systems just before COVID. And these were systems that, weren't flawless, but they had some strengths. Marcia and Alberto have stressed that. But my question is whether we have any sense of whether there's will be more of an appetite for fixing these public healthcare systems after this pandemic. In Brazil, I can speak about with a little bit more knowledge than Mexico. A big constraint on social spending in Brazil was a fiscal reform that was passed called the teto, or the ceiling, which capped public sector spending. The real motive of that spending cap was to get a hold of pension payments. I don't think that the healthcare system was as much a target as the target was to force Congress to pass a pension reform. They have their pension reform now. Is there any public appetite or pressure for going back to sort of restoring functioning healthcare systems in these countries? And in Mexico, Alberto said that there's been a shift. Governors don't like the new system, but out of this crisis, can we imagine a future where the federal government has to subsidize the poorest 25% of tiny municipalities. Can we imagine a place where we have family teams once again visiting people and delivering primary care? It may be in ways that would be more racially and ethnically just than in the past. I know that's a hard question, but that's my question. Where do we go from here?
Yeah, you left the easy question to the end, right? So I think we have to keep imagining a future when those things happen, because if we don't, then, we give up. I would love to know what the government has appetite for, because other than, just creating more disruption and destruction, I don't know what's the agenda. I mean, any government in Brazil that does not have the work inequality in the agenda, I don't know what they're going to do. And there's not a single program that is trying to address exactly those inequalities that that we have in society. So my hope is this: we have a lot of young people running for the local elections now, and they're going to receive municipalities in a total chaos, right? There's not going to be any easy job for any of the mayors. They're going to, either continue to a second term or take a first term. Now, what I hope is that some of the new ideas, the new hope, I like Star Wars, so the new will come now with the local elections. And then I hope those people are gonna, bring some fuel to get people mobilized in the next 2 years, so we can, through the vote, which is really the only tool we have to change those things, it's through the vote, try to promote a change. But I would not hold my breath expecting that the current government is suddenly shift and look at the poor, the vulnerable. And no, that's, even with all the hope I can put together, that's not going to happen. But through those elections and through people really trying to work at the local level and bringing from the local level to the top, I think that's where the hope lies. And may the force be with them, I guess. But
Okay, a last 30-second political answer from either Alberto.
Can I add just a little thing? I mean, more on the optimistic side of things of political science, social science in general. I think we need to force every epidemiologist to include some questions on trust and a perle la palette on everything they're doing. I think we are just missing out on a hugely important effort to collect data on how there is this differential impact and also the mechanisms through which people create expectations of their own health. So I think we need to force this a little bit more. And just one last little thing, just underscoring what Marcia said, the 1546 epidemics in Mexico, 1576, probably more people died from the famines that followed them than from the direct death from the epidemics themselves. So we really need to address this as a sort of very structural thing. I think Francis pushed us in that direction.
Let me just say real quickly, in response to some of the questions about other Latin American countries. Well, I think the data collection on race and ethnicity in Mexico, and especially in Brazil, are just way better than most places. And for the other Latin American countries, we have terrible data collection. I mean, it's the best social policy, or the newest social policy on race and ethnicity, is data collection. But in the censuses, many of the health systems throughout Latin America don't have data on this. I mean, there's clearly the different national responses, and that's what we focus on, but there's a huge variation in the quality of data collection.
Wonderful. That's a perfect note to end on. So thank you all for underscoring what we already are starting to learn about the disparities that are emerging in response to COVID. And obviously there's a huge need for more data collection and further research to really get a sense of the range of impacts that communities are feeling from COVID-19 and the aftermath. Also, there were many discussions about subnational variation. So if you are interested in that topic, please come back next week when we have Agustina Gorali and Kent Eaton thinking about subnational and federal responses to COVID. But today, I just want to give a very warm thank you to our panelists, as well as all the audience members that asked questions. It was really an enlightening and wonderful discussion. So thank you for joining us today. And
Thanks,
see you all
everyone.
next week.